Good morning, Dr. Mitchell.
Good morning.
Now, let me explain, before you are given the oath to swear, what our setup is, so that you understand, so that those who are present in the hearing room understand, and those who are watching remotely understand. You are, as I understand it, at home.
Yes, I am.
And your legal representative, your solicitor, is watching remotely.
Yes.
And there are two members of the inquiry staff at your house, but not in it.
That's true.
I think your wife is in the house.
She's downstairs, yes.
Now, that's your position. What you need to know is that you're talking to a room in which there are four members of the inquiry legal team. There are four members of the inquiry staff, and there is a technician whose job it is to make sure that the right documents are displayed at the right time whenever they become relevant. That's the extent of the number of people in a very large room. You'll understand immediately that we're all properly socially distanced.
Yes.
And although it would have been my preference to have had you here so that you could see us, we could see you, and there would be that sense of immediacy and presence, those who would have been here, had it not been for the virus, if I can call it that, the coronavirus, they are watching remotely. They have you visually available to them, and they have a sound feed. They will, at the end of the day, and during the day for most, a transcript of what you are saying, so that there is a permanent record of it. That will be checked at the end of the day so that we know that it's accurate and corresponds to what you actually said. So those are the arrangements. We take a break normally halfway through the morning for lunch and halfway through the afternoon to enable you to get a break and some refreshment if you want, and for those who are watching to do exactly the same, as well as those here. So that's the setup. I'm going to ask you now to take the oath. Mary, one of our members of staff, will ask you.
Please state your full name.
Vivian Eric Mitchell.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Good morning, Dr. Mitchell. Can you see and hear me?
Yes, I can.
I'm going to start just by asking you to help us with an overview of your career. Your statement tells us that you undertook your general medical rotation in Sheffield hospitals from 1970 to 1973. Is that right?
That's correct.
And then between 1973 and 1975, you were working in Wales. Could you just give us an overview of where you worked and what kind of work and training you were undertaking there?
I was a registrar for 2 years. Most of it was at the University Hospital of Wales in Heath Park in the north of Cardiff. 6 months of it was in Lendock Hospital, which is on the western outskirts of Cardiff in Penarth. As I come from a medical background as opposed to a pathology one, they put me through the various laboratories. So I did a lot of laboratory hematology. First of all in blood bank, then in coagulation and in the general laboratory. And in fact, that led to my being on call as an MLSO for 6 months. They were quite keen on that. I also did 3 or 4 months clinical work with Jack Whitaker, concerned with malignant and non-malignant hematological disorders on the ward. I spent about 2 to 3 months in coagulation with Professor Bloom.
Can you recall anything in relation to the 2 to 3 months you spent with Professor Bloom? Can you recall anything about the approach to treatment or the policies in relation to treatment at that time?
Not really, no. I think we were using some concentrate, particularly I believe we're using some factor 9 concentrate. Even then, a lot of the time was spent in the laboratory learning coagulation techniques. It's an area they felt I was lacking in because of my background.
And did you have any involvement in decision-making relating to choices of products or treatment plans for patients?
Not at all.
You then moved to the Sheffield Royal Infirmary, where you worked from 1975 to 1978 as a senior registrar in haematology.
Yes.
And I think it was during this time that you undertook your MRC PATH exams?
Yes, towards the end of that time, yes.
You had 6 months at the Northern General Hospital. Briefly, what did that entail?
General and malignant haematology. It's not a haemophilia centre. There are 2 consultants, and we had inpatients, outpatients, and as I say, it was general malignant haematology and laboratory work.
And then you had a secondment during that time to the Blood Transfusion Centre in Sheffield. Was that under Dr. Wagstaff?
Yes, it was. Yes.
And what did that entail?
We rotated through the various departments in the Blood Transfusion Centre. There were a lot of exercises. There was a lot of technical work in the MRC PATH in those days. You would expect it to be quite proficient in blood transfusion, coagulation, and other laboratory techniques. So one of the senior MNSOs would set up an exercise for me to do in the afternoon. I also did some sessions for them when they were short, going out onto the blood transfusion sessions. And when in those days, there was always a doctor present at those sessions. And I fielded some of the telephone calls and so on from people asking for blood and blood products.
Do you recall during that secondment any discussions or any training in relation to pool sizes or risks of viral transmission?
No, obviously we knew about testing for hepatitis B, which had been in place for some years. I don't remember a discussion about pool sizes. Obviously, the only product, they made fresh frozen plasma and cryoprecipitate there, but plasma for concentrates would be sent off to BPL.
And then the majority of this period, 1975 to 1978, is it right you were working with Professor Preston in Sheffield in the haematology, in the Haemophilia Centre?
Well, with Professor Preston and Professor Blackburn, of course. Yes. Professor Blackburn was actually head of department at that time, yes.
And what, if anything, can you recall about the approach to treatment taken by Professor Blackburn and Dr. Preston, as he would then have been?
Most of my time, even then, was involved with patients with malignant blood disorders. It's to a large extent, what the senior registrars did. I don't think I even attended the haemophilia review clinics. But the patients with haemophilia were treated on a ward, in a room adjacent to one of the wards where we had adult patients. They were treated, I think, largely with concentrate. I don't think there was a specific concentrate. I think there were several concentrates in use. I'm sure we used cryoprecipitate as well, but I can't remember how the patients were divided up.
Okay. You had some involvement in the Sheffield study, which was reported in the Lancet in 1978. I'm just going to put that on screen.
Okay.
Shumik, it's PRSE 303622. And if we zoom in on the right-hand column, please, top half of the page. So we've looked at this already within the inquiry, Dr. Mitchell, on a number of occasions, but we can see it's the Lancet, 16th of September 1978. It's the article entitled Percutaneous Liver Biopsy and Chronic Liver Disease in Haemophiliacs, and there are a number of names there recorded, including Dr. Triggers, Professor Preston, Professor Blackburn, and we see your name there, V.E. Mitchell. And your capacity or your role at the time was a senior registrar.
Yes.
Can you recall what your involvement in the study was?
Basically looking after the patients. So I admitted them on a Monday, clerked them in, worked out their dosage according to a protocol that Professor Preston had provided. Dr. Trigger came and talked to them on the Tuesday, did the liver biopsy, and he was a considerable expert in hepatology. And then they were treated for several days and then discharged on the Friday. So it was really looking after the patients whilst they were in hospital.
And I'm not going to go through the detail of the article because we've looked at it on a number of occasions, but what you've said in your witness statement is that you understood from this work that at least in some patients, liver disease was significant and progressive. Is that right?
Yes, that's true. I mean, Professor Underwood, we had meetings with Professor Underwood where he demonstrated the histopathology, and at that time, some of the pathology, chronic persistent hepatitis, for example, was regarded as non-progressive. But there were some patients who showed progressive disease, including, I believe, two of the patients with mild haemophilia. Yes.
You were also involved, your statement tells us, in an early study of the use of DDAVP in haemophilia. We don't, I'm afraid, have any specific documentation in relation to that, although you've given us a reference in your statement. What if anything, can you recall about that DDAVP study?
I think the use of DDAVP in mild haemophilia had been reported possibly the year before or the same year by Professor Minucci. And I think Professor Preston thought it was a good idea to actually establish our own study, that it would work in our hands and to see how successful it was. And of course, it was important to do, because it doesn't work in every patient as well as you would like it to. By doing it once, you would actually know whether it would work in that patient at future times. So I think it largely confirmed the findings of Professor Minucci. But it meant that Professor Preston and Sheffield were using DDAVP at a very early stage. I read a review by Professor Minucci, and he wrote a lot of those, saying that he thought the take-up of DDAVP to treat haemophilia in the rest of Europe had been very slow. Well, that wasn't true of Sheffield.
You then, between 1978 and 1979, were a research fellow at Sheffield University.
Yes, that's true.
And then in November 1979, you took up a post as consultant haematologist in Leicester and director of the Haemophilia Centre.
I'm not sure they characterised me as director of the Haemophilia Centre, but I was made responsible for haemostasis, including haemophilia.
And you remained in that post until your retirement in November 2003?
Well, I retired in March 2003, but then was asked back for 6 months.
Now, I just wanted to ask you a little about the facilities in Leicester before you arrived, which we can pick up from an article that I understand you wrote in the Bulletin. Shumik, it's HCDO 40-276_061. No, that's not correct, I think. Sorry. HCDO 40-276-043. underscore 043. Sorry. Do you have that? HCDO 0000276 underscore 043. And then if we could go, please, to page 4, I think. So this is an article which I understand to have been written by you, and in the left-hand column, you describe the lack of services in Leicestershire in, I think, the early part of the 1970s. And then if we go down to where it says no centre, please, Shumik, if we could see the bottom half of the page. You say this, there weren't haematologists, there was no centre, and then I think it says the blood transfusion service would not allow even cryoprecipitate to be stored in Leicestershire. And then you've described patients having to leave Leicestershire to seek treatment elsewhere or travel long distances to obtain treatment. And then how in 1973, Dr. Wood was appointed as the first consultant haematologist. In 1975, he was joined by Dr. Hutchinson, and they were able, with the support of Professor Blackburn, to establish Leicester as a haemophilia centre. And then you go on to describe how towards the end of 1980, so a year or so into your appointment, a new haematology department opened with a purpose-built haemophilia centre. Is that an accurate summary?
Yes, that's fair enough, yes.
So by the time you arrived, there were 2 consultants in post, but you, as I understand it, undertook a range of haematology duties, but you took particular responsibility for haemostasis and the care of patients with bleeding disorders.
Yes, we were, I mean, even by the standards of the day, we were very understaffed from a consultant point of view. There were only 3 of us, and there were 3 major hospitals. Most of my work, in fact, was in malignant haematology, laboratory haematology, and I was made responsible, as well as taking referrals from the infirmary, I was made personally responsible for one of these other hospitals, Glenfield Hospital, which if it had been 20 miles away, would have had 2 consultant haematologists. But because it was only 4 miles away, it was served, if you like, from the LRI. We were very large from a laboratory point of view, with 3 departments, 3 blood banks, and over 70 MLSO staff. But we were very short on consultants. So my colleagues had wanted somebody to take over a section, and in fact, first of all, they advertised for a pediatric haematologist. So it was almost fortuitous that I came along to do hemostasis. And it was 10 years before we got a 4th consultant, which I think none was expected.
And when you arrived, there was no haemophilia nurse, but a nurse was appointed in early 1981.
Yes.
And she was, I think your statement tells us, the first in the Trent region, and your understanding is one of the first in the UK to have a specialist nursing role.
I don't think there were many in the UK at that time. I think I heard Charlie Hay say, I think, that he didn't know about haemophilia nurses till 1987 when he came across them at a haemophilia seminar. So it wasn't all that common then. And she was a great boon.
And your statement tells us, I think, she was involved in matters such as home and school visits, training patients and their parents for home therapy, liaising with the local haemophilia society, and then we'll come on at a later stage to her role in relation to HIV and HCV testing. We're just going to look at a statement, an annual return from 1976, so before you arrived, but just to get an idea of numbers of patients being treated at that time. It's HCDO 5063 underscore 004, I think, or it might be 83, sorry. Try 63. So we can see here, this is a return from 1976, and we get a sense of the number of patients, total number of haemophilic patients treated during the year 20, total number of Christmas disease patients treated during the year 4, and then we can see usage of cryoprecipitate. This form doesn't distinguish between hospital and home treatment. And then in terms of concentrates, ARMA factor 8 being used, and immunocryobulin, not apparently any NHS concentrates in 1976, and then NHS factor 9 concentrates being used for the care of patients with haemophilia B. So that's 1976. When you arrived in late 1979, what, if anything, can you recall about the approach to treatment at that stage? What did you find?
Well, if I could comment on this form a little, the thing that surprises me here, that with 20 patients with haemophilia A, they're only using about 180,000 units, which is a tiny, tiny amount of treatment, and would work out at about 9,000 units per patient per year. So it may be that this isn't a whole year, or that the treatment of haemophilia had just started, if you like, just got underway. When I arrived, there had been 3 intervening years, of course, and home treatment was already established. And I believe all the patients on home treatment were on commercial concentrate. There was NHS factor 8 concentrate being used in the centre at that time, but I don't think there was a great deal of it initially.
Now, you have said in your witness statement that the treatment policy which you adopted in Leicester was explicitly based on the reduction of risk and based on restricting the use of large donor pool concentrates whenever possible. Can you just elaborate a little upon your thinking, please?
I was convinced by the Sheffield work and the Sheffield report that there was a connection between the use of multi-donor factor concentrates and the development of liver disease. And I was further convinced that in some patients this could be progressive. And although there was doubt about the pathogenesis, the way in which the liver disease had occurred, it didn't really seem to matter. Whatever the pathogenesis was, the way to protect patients was to try and reduce, as far as possible, their exposure to multi-donor factor concentrates. And I came up with a policy which seemed to me, rightly or wrongly, to be a reasonable approach at that time.
We'll go through the different elements of the policy in a moment. What you've said in your statement is that you essentially had to formulate your own policy. Was that because of an absence of any kind of national or regional guidance?
As far as I'm aware, yes, I wasn't aware of any. I must say I was, to a large extent, professionally isolated from a hemostasis point of view. I was a long way away from Sheffield, 70 miles from the reference centre, and the reference centre didn't really play much of a role in guiding policy in Leicester. And there was nobody else other than myself and the sister who was really interested in hemostasis and haemophilia care. So I was professionally isolated, I suppose.
Now, the elements of your policy, first of all, in relation to patients with mild or moderate haemophilia and von Willebrand's disease, your approach was to use DDAVP and tranexamic acid wherever possible. Is that right?
Yes. although in moderate haemophilia, it may well not be sufficient.
Did you have any difficulty obtaining sufficient supplies of DDAVP or tranexamic acid?
No.
And in relation to DDAVP, did you use it on its own without tranexamic acid, or were they always used in combination?
I don't remember, but I think certainly with a dental extraction or something like that, mucosal bleeding, they would have been used jointly. I'm not sure whether we always used them jointly, but I think quite often we did.
And do you recall whether there were any particular or frequent difficulties with the use of DDAVP, or was it generally a successful mode of treatment for patients in those categories?
I mean, there were precautions you had to take. It could result in fluid retention, for example. There's the tachyphylaxis, so that the response diminishes over time. You had to do a trial to make sure that because the response varied from patient to patient. So if you were aiming at an operative procedure, then you would need to do a trial first to make sure that particular patient responded as hoped. But we used it fairly often, I think.
And again, for these cohorts of patients, so patients with mild or moderate haemophilia and von Willebrand's, if you weren't able to use DDAVP with or without tranexamic acid, your policy was to use cryoprecipitate.
Where possible, where feasible. Obviously, if someone was having a major operation with mild haemophilia, I mean, I think the inquiry has mentioned the mild haemophiliac from outside of Leicester who required open heart surgery, then DDAVP, we could use DDAVP to cover his catheterization, but we couldn't use DDAVP to cover his open heart surgery.
And in relation to that kind of surgery, could you use cryoprecipitate, or were you then required to use concentrates?
I'd use concentrate.
Okay, and we'll come on to that specific instance at a later stage. So DDAVP and cryo generally for mild to moderate patients in von Willebrand's. And then with children who had severe haemophilia, your policy was to treat them with cryoprecipitate until such time as they went on to home treatment. Is that correct?
That's correct.
Do you recall roughly, typically at what age a child would start on home treatment? Or was there
I've been trying to
such
think about that, and I honestly I can't. I think we may have been later than some other centres, so I think it may have been around about 10 or something like that.
And I think you've said in your statement that the decision as to when to convert to home treatment would depend upon parents' wishes, frequency of bleeds, and ease of venous access.
Yes, and how well the parents got on with the training that the sister was giving them.
Did you have any difficulty obtaining sufficient quantities of cryoprecipitate for use in the way in which you've described?
No, I don't remember that we did.
Did you experience significant issues with allergic or other reactions to cryoprecipitate?
Certainly it was known. I'm sure it may have happened. I don't remember it being a major problem, but it's certainly an unwanted effect that is known. I've seen it more often with fresh frozen plasma, in fact, but yes, it does happen.
And did the patients who were being treated with cryoprecipitate, whether they were adults with mild or moderate haemophilia or the parents of children being treated with cryoprecipitate, did they have any issues or protest about the fact that they would need to attend hospitals for bleeds to be treated with cryoprecipitate?
Not often. I can remember one mother who was very keen for her child to go on to home treatment, and who I believe wrote to the Haemophilia Society about it, who then forwarded her letter to me. But she was actually she was a single mother, and she was having considerable difficulty with the procedure, with the venipuncture with her son. And we got her onto home treatment as quickly as we could. But by and large, no. I suppose we were lucky in a way that we're in Leicester, in the middle of the county. Most of our patients were actually from Leicestershire, so nobody was further away than 20 miles. And in fact, most of them, because of the way the population is figured, I mean, you have Leicester with 300,000, and 2/3 of the rest of the population live in villages and towns surrounding Leicester. So most of our patients didn't have to travel far to get to the centre, and that probably helped.
And do you recall whether you told your patients that the basis for your approach to their treatment was one of safety and reduction of risk?
I'm sure we did. I don't specifically remember saying that to the people receiving cryoprecipitate.
Then in relation to adults with severe haemophilia, and I'm talking here about haemophilia A for present purposes, your approach, as I understand it from your statement, was as much as possible to treat adult severely affected patients with NHS factor concentrates.
Yes.
But as I understand your statement, there were insufficient supplies of NHS factor concentrates, and therefore you also had to use within the centre commercial concentrates.
Yes.
You obtained cryoprecipitate, I think, from the Regional Transfusion Centre. The NHS factor concentrates, were they supplied to you directly from BPL?
No, I believe they also came from Longley Lane. Yes.
And
from Sheffield.
do you recall anything about how the system for allocating NHS concentrates worked within the Trent region?
I think it was decided by the director, Dr. Bill Wagstaff. I certainly spoke to him to try and get our allocation increased, and I think he did do so. I mean, obviously there was a tradition that most of this went to Sheffield, but even for their purposes, it was insufficient for them to treat the majority of their patients.
And your statement says that you would certainly have used more NHS product if it were available.
Absolutely.
And so the second element of your policy in relation to the treatment of adults with severe haemophilia A was, if you were using commercial concentrate, to adhere to one single concentrate as much as possible.
As much as possible, one batch of one commercial concentrate, yes. That was our policy.
When you arrived, I understand that Coate, which was produced by Cutter, was the commercial concentrate most often used in Leicester, and you essentially continued its use, is that right?
Well, that's what I remembered. The things you've sent me suggests that there were Humanate and possibly others were also in use at certainly 2 or 3 years before then. So I'm not sure, but my memory was that I would have continued with whatever intermediate purity product was in use then. But if there are documents which are missing, aren't there? And I don't really know what happened between 76 and 80.
And you say in your statement that you would buy as much as possible of a batch from a single commercial supplier. And you say in this way, patients have been treated for as long as 18 months using 100,000 units or more of the same batch. How did that reserving batches or batch dedication policy work in practice?
Well, we would hope to only have one batch of one product in the hospital, except obviously at the times when we were changing over, and that the system made up the home treatment packs, which are kept in the cold room and the blood transfusion laboratory, labelled for the patient, so that when they arrived, she would be able to hand this over to them, to sign it out to them. I suppose that was it really. We would try just to have one batch of one product, so that people couldn't make mistakes out of ours.
As far as you can recall, did you experience any difficulties in obtaining sufficient supplies of the one product that you seem to have predominantly used, at least the COAT?
I would have said no, but I know you have a document which suggests that we had to resort to BPL product at one stage with one patient.
Yes, well, just look at that for the sake of completeness. WITN 1167004, I think. So this is an extract from a patient's UK HCDO records, and I appreciate you won't have had any access to any other records relating to this individual patient or others. But this shows predominant usage of Cutter's factor 8, COAT, but some usage in 1980 and 81 of Human 8, and indeed of factor 8 in 1981, and also of the BPL, the NHS concentrate in 1980 and 1984. So that would suggest, if these records are accurate, that you weren't always able to achieve compliance with your single concentrate policy.
I don't think that's quite the case. I think what it means is that in my first year, for instance, I think it was fairly frantic, and I was predominantly doing malignant hematology and other hematology work. So, and there was no centre, there was no sister. I think it probably took us a year or so to test. Although I had the policy, I think it probably took us a year or so to fully implement it. And from this, it would look like it was implemented with this patient from 1981 onwards. The thing that more concerns me is the fact that the patient was given BPL factor 8 in 1984, and I'm not clear of for the reason that happened. If it had been the end of 84, I would have thought that perhaps we were, with increased access to NHS factor 8, we were using that before the patient switched on to heat-treated commercial concentrate. But unless these are out of order, it seems to be in the first half of 1984 that he was, for some reason, given BPL factor 8. So, I mean, I think that's the bit that's out of the policy rather than the early treatments.
Okay, thank you. To what extent was it part of the approach to treatment at Leicester to give lifestyle advice to patients to try and avoid bleeds and thus avoid the need for treatment?
I think it was standard that we would tell people. We wanted, particularly the boys and young men, to live as normal a life as possible. I mean, they are normal people, but we would obviously have to advise them against contact sports like rugby and so on. And but it was very important that they did exercise, that they kept their muscles healthy, because that protects the joints. I mean, swimming was the particular sport that we would advocate. So we did try to get them to avoid injury, but we also wanted them to live a full and happy life. So we had to be balanced about it.
And then your policy in relation to the treatment of patients with haemophilia B was, is this correct, to use NHS factor 9 concentrates?
Yes.
I know there were a couple of instances of usage of commercial factor 9 concentrates, but we'll come on to that at a later stage.
Just one, I think.
But generally speaking, it was NHS factor 9.
Yes.
We'll look at the 1983 returns. So this is HCDO 0000150_002, please, Tumik. And if we go to the second page, please.
That page is interesting because it says registered Oxford. I think there are several other mentions of that, and that does show that those patients were travelling to Oxford for their treatment before treatment was available in Leicester. I mean, there will be people at Oxford who've written the register at Oxford on the returns.
And then if we go to the second page, so we can see here, this is the annual return for 1983. Total number of haemophilia A patients treated during the year 31, and total number of von Willebrand's disease patients treated during the year 6. And then we can see there the usage of cryoprecipitate in hospital for the treatment of haemophilia A patients. 388 bags, 27,160 units, presumably, is the calculation there. And then NHS factor concentrates being used in hospital, 152,455, and then at home, 57,850. And Qatar, Co-8, 128,050 in hospital, 423,870 for home treatment. And then down the bottom of the page, we've got DDAVP. And then to the right-hand columns, we've got von Willebrand's disease, cryoprecipitate. So this would suggest that certainly by 1983, you were using a sole commercial product, Co-8.
Yes.
In particular for home treatment, with a much smaller amount of NHS concentrates being used for home treatment.
I think when I arrived, the majority of patients on home treatment were on commercial concentrate, and I didn't really have the ability to switch them over to NHS with the amount of NHS we were receiving. So that was continued.
And then if we go on to page 4, I think it should be, this is the annual return in relation to patients with haemophilia B. We can see that you treated 8 patients with haemophilia B during that year and 1 carrier of haemophilia B. And the treatment is NHS factor 9 concentrate used both in hospital and for home treatment. And then other materials, FFP, fresh frozen plasma, and that's been used for the carrier of haemophilia B for inpatient treatment.
Yes.
And then if we go to, no, I think we'll come on to a later return at a later stage. In terms of the home treatment programme, were all the patients who were on home treatment patients with either severe haemophilia A or patients with haemophilia B?
They were always severe haemophilia A or B, yes.
So no patients with mild or moderate. And was there any home treatment programme for von Willebrand's patients?
No.
How and when, as far as you can recall, did you become aware of the association between the use of factor concentrates and AIDS?
I'm not at all sure. 1983, 84.
In terms of information that you might have had, what journals did you generally read at that time?
Well, I received a BMJ as a member. I subscribed to New England Medical Journal. I received the British Journal of Haematology as a member. But I must say that, of course, I had to keep abreast of right across the field of haematology. So I heard someone, I think it was Mark, say British Journal of Haematology didn't have much haemophilia in it. It had an awful lot of haematology. So I was not concentrating on the haemophilia literature alone.
We know that there were publications, for example, in January of 1983 in the New England Journal of Medicine, which talked about the occurrence of AIDS in haemophiliacs in the States. Is it likely that you would have read those at the time?
It's perfectly possible, yes.
And we'll go to one document that you, I think, would have received at the time. Shimmick, it's HCDO 40517 _ 001. So you'll see, Dr. Mitchell, this is a letter dated the 22nd of March 1983. If we go to the second page for a moment, please, Shumik. We'll see that it's authored by Dr. Krask, Dr. Ritzer and Professor Bloom, and it's been sent out on behalf of the UK HCDO. So if we go back to the first page, it's Dear Director, it's headed AIDS. It refers to discussions in the Hepatitis Working Party and a recent meeting of reference centre directors. And then it invites directors to essentially report any possible cases of AIDS to the authors of the letter. Do you recall, as a matter of fact, this letter at all?
Not as a matter of fact, no. But if it went to all haemophilia directors, I would have received it.
That's certainly our understanding, Dr. Mitchell. That was its purpose. Just looking at the first paragraph, which refers to discussions in the Hepatitis Working Party and a meeting of reference centre directors. Did you, at the time, as a director but not a reference centre director and not a member of the Hepatitis Working Party, did you receive the reports or minutes of those working parties or of reference centre director meetings?
No.
And then if we go, please, Shumik, to HCDO 40517_002. This is a report from Dr. Krask, dated the 1st of March 1983, which we understand may have accompanied this letter. Again, I'm not sure whether have you got any actual recollection of seeing this report at the time?
No, but I'd seen similar things, I think, about Kaposi sarcoma and pneumocystis carinii, yes, so I may well have had.
And then if we go to page 3, we can see the bottom half of the page under the heading Etiology. There's a discussion by Dr. Krask of various theories. He refers to the possibility of drugs such as amyl nitrate and then discounts that. He refers to cytomegalovirus and then discounts that as seeming unlikely. And then we go over the page to his point 3. He refers to the likelihood of an infectious agent with a similar epidemiology to that of hepatitis B. And then he goes on to say if 3 is the most likely cause, it's possible such an agent might be present in plasma pools. If we go to the last page, please. Oh, I'm sorry, the page before that. My apologies, Shumik. We can see the last paragraph says it's thought likely that batches of factor VIII concentrate which might contain the AIDS agent came into use since January the 1st, 1980 in the USA, and then goes to talk about the setting up of a reporting system, reporting cases of AIDS. And then just to complete the picture, there's one further document. Shumik, it's HCDO 40273_078. This is a headed Acquired Immune Deficiency Syndrome Survey, Spectrum of Disease Presentation in AIDS. And it says, please complete and return to Miss Spooner at Oxford a report form AIDS 3 for all patients with blood coagulation defects seen by your centre who fulfil any of the following criteria. And then on that page and over the page, there's a list of symptoms and signs and abnormalities to look out for. I won't go through the detail of it with you, Dr. Mitchell, but is it fair to assume that by March of 1983, you would have had at least the knowledge that's set out in these documents?
Yes, I think so, although many of the clinical conditions there are very rare. As I understood it, the presentation was more likely to be candidiasis or pneumocystis pneumonia, but Yes, I presume I received these documents.
Now, did you, as far as you can recall, provide your patients with any information at this time, spring of 1983 onwards, about possible risks of AIDS from use of factor concentrates?
I think both I and the sister will have talked to patients about this. I think many of them were already aware because of reports in the media that there was this association.
So you think you would have done? Can you remember, and I appreciate I'm asking you about matters of many years ago, but can you remember as a matter of fact whether it became your routine practice to do so, or whether it was only if it was raised by a patient?
No, I can't.
No. Now, as I understand your statement, your approach to treatment of patients didn't alter because the policy, you say in your statement, that you had in place to try to reduce the risk of liver disease was equally applicable to HIV and was therefore continued.
I mean, both were my idea of how to try and reduce transmission of an agent, whether that was a virus or not. I mean, the argument about pathogenesis is largely irrelevant, really. If the harm is being done by the concentrates, then you try and reduce exposure to concentrates. And I suppose I felt that it was very important to carry on treating patients, but I would do all I could to try and reduce the exposure of the patient.
Can you recall whether you gave any active consideration at the time to the suspension of home treatment, for example, on a temporary basis?
And substituting what?
And patients coming into the hospital to be treated with cryoprecipitate?
Yes. I don't think I gave it active consideration, excuse me. I mean, one of the problems was that many of the patients in Leicester had received inadequate treatment. There was many of them had more severe joint problems than I was familiar with seeing in Sheffield. Some of them almost resembled the situation I saw in Karachi and Lahore many years later. So there are many patients who had very severe haemophiliac arthropathy, and the idea of returning them to inadequate treatment, or what I felt was inadequate treatment, would not have appealed to me. You could compare that with the situation in the early 1990s when I had lads with severe haemophilia who were competing with local swimming clubs, and one of whom was working weekends as a lifeguard. I mean, these were muscled young men, you know, who were fit and healthy and living normal lives. I think returning to inadequate treatment would not have been something I would seriously have considered.
Do you recall whether you gave any consideration to perhaps using porcine product, high 8C, for some patients or some bleeds, other than for the use of inhibitors?
I did use it for inhibitors. I do not remember considering it for the treatment of people of haemophilia A patients. Without that, it did have some disadvantages, and I understand that many patients became resistant to it with continued use.
We've had some evidence from in relation to some centres that possibly in 1984 an approach was taken to defer non-urgent surgery because of the risk of AIDS. Do you recall whether that was something that was considered locally in Leicester?
I don't think we did any surgery at that time. So I think we were trying to do that, yes.
Now, there came a point in time, I understand from your statement, probably in early 1985, when patients were transferred to heat-treated product. And we'll just look at a couple of documents in relation to that. Shimik, could we have, first of all, CBLA 302067? We can see that this is a letter from you to Dr. Snape at BPL. It's dated the 25th of February 1985, and it is in relation to obtaining supplies of heated factor 8 concentrate for some patients who were regular users of NHS product. You then go on to say, we have several children who at present only receive cryoprecipitate but are in the severely affected category and might be expected to go on to home treatment in the next year or so. You then tell us there are 39 patients with mild to moderate severity haemophilia who might require treatment with factor 8 concentrate in certain circumstances, and another patient with severe von Willebrand's who might be a potential user of NHS factor concentrates, heat-treated concentrates. And then if we look at the handwritten PS, says, I've not included our severely affected adults at present receiving commercial heat-treated product. So it would appear that certainly by the 25th of February 1985, you were receiving commercial heat-treated product. I think you were again using the COAT heat-treated product.
That's true, yes.
For severe haemophiliacs who were already being treated with commercial concentrates. Is that right?
Yes.
And then for this, the cohort described in the first paragraph of this statement, so patients who had been treated with NHS product and you were trying to get the heat-treated NHS product, at this point in time, were they still receiving treatment with unheated NHS product, as far as you recall?
Yes.
And do you know how long it took for you to receive sufficient supplies of heated NHS concentrate to be able to treat this group of patients with it?
I can't remember exactly when we started to receive NHS heat-treated concentrate. I should think it was that summer.
And then if we look at one further document, it's CGRA 40559, please. Shimik. If we go to the second page, I should say I don't think we have a date for this, but it appears to be an internal cutter document in any event. It's giving details about COAT and COAT HT sales, so the heat-treated COAT. If we just look at the bottom half of the page, COAT returned material, it says this: the December figures show returned COAT from only the 2 centres, but the following centres have subsequently returned or are in the process of returning material. And then we can see Leicester is there identified. And then underneath that table, it says all the centres which returned COAT in December and those subsequently have replaced with COAT HT. So this, it looks from this as though in early 1985, you were seeking to return your unheated COAT to cutters and to receive heat-treated COAT in return. Does that accord with your recollection?
I don't remember it specifically, but certainly that it looks as if that's what we and many other centres were doing. And it makes sense, I think.
Do you recall whether you took any steps in relation to your patients who were on home treatment and who might have supplies of COAT, unheated COAT at home? Did you take any steps to ask them to bring that in so that they could have it exchanged for heat-treated products?
I don't remember whether the sister did that, but we certainly seem to be returning quite a large amount of products compared with some of the other centres there. So it may well be that we did take back material from the home treaters.
And then in relation to obtaining heat-treated products, your statement suggested you had to get permission to increase the centre's spending, but it was given and the delay was not major.
That's my understanding. I used to. It was ordered by Mr. Godfrey. He was the chief pharmacist. They called him the unit pharmacist because the LRI was just one unit of the trust. He was always very helpful, but in the case of a major and continuing expenditure like this, he would have to pass it upwards. And sometimes I got involved in discussions with the medical director and the chief executive too. This became an increasing problem later on, but I don't think on this occasion we had a great delay. It wasn't something the unit pharmacist could do on his own.
And then in relation to factor 9 concentrate for your haemophilia B patients, your statement says that the NHS factor 9 became available, I think you suggest, from the autumn of 1985. Prior to that, you used non-heat treated NHS factor 9 in preference to commercial products because you didn't consider the commercial products to be safer. Is that correct?
I wasn't convinced of the safety of the first lot of commercial heat-treated concentrate. I was a great believer in the British voluntary donor system, and also the virucidal methods to be used by BPL were much stronger, much more, I thought, likely to be effective. And I also wasn't keen to change all my patients onto intermediate purity heat-treated products and then move them back onto NHS products a few months later, because I was always trying not to expose people to large donor pools. So those were, I think, my thinking.
And then could we have on screen, please, Shimik, BAYP 607_045, please. This is an internal Qatar memo dated the 4th of July 1985. We'll just go to the second page, please, Shimik. And under the heading Leicester, it says this: the problems we encountered at Leicester during the last 3 months are almost over. These problems were lack of stock and not being able to reserve batches for them, and pressure on Dr. Mitchell to use Prophylate HT on 6 virgin haemophiliacs. Our supplies to Leicester are back to normal. We're now able to reserve small batches for their patients, and despite all pressure from Barry Barber or Dr. Mitchell, 4 out of the 6 virgin haemophiliacs are now using Coate HT. The other 2 patients continue to use cryoprecipitate. What, if anything, can you recall about the events that seem to be described here?
I don't know whether this is correct. I'm not sure that we had 6 patients. We transferred 6 virgin haemophiliacs, as he calls them. They won't have been virgin haemophiliacs at all. There have been patients who have been treated for many years with cryoprecipitate, so they weren't previously untreated patients. And I don't know whether we transferred 4 of those to Coate HT. It may have been that we discussed it with the parents and said, do you want to wait until the BPL product, which I would have preferred as a product if it had been available, or do you want to transfer over to commercial HT? So I can't say whether this is correct or not. I don't think everything well, certainly, as I've shown later, not everything in these internal memos was correct.
I think your statement looking at this suggests that it might mean that you had 6 patients to transfer from cryoprecipitate to heat-treated concentrate, and that you might have been keeping them on cryoprecipitate longer to wait for the heat-treated coate to become available. Is that a possibility?
That is a possibility, yes. I think we did certainly suggest that we did that, but whether we'd put them onto coate HT or NHS product, I'm not sure. Certainly our NHS usage increased considerably.
And then we'll just look at the return for 1986 to complete the picture as well in terms of product usage. Schumach, it's HCDO 40333_002. And then, so we can see this is the annual return for 1986, 38 haemophilia A patients treated in 1986, 7 von Willebrand's disease patients treated in 1986. We can see there that you're, for the haemophilia A patients, still using cryoprecipitate in hospital. There is then an increase in the amount of NHS concentrate being used, so 271,000 odd in hospital, 240,000 odd units for home treatment. And then there is only one commercial concentrate identified, that's coate, 174,570 hospital, and then 472,710 home treatment. And then we can see towards the bottom of the page, you're using the porcine product. That would be, as you've earlier referred, for a patient or patients with inhibitors.
Yes.
And then DDAVP, tranexamic acid. And then there's a reference to topical thrombin, I think. What was that for?
Sometimes in babies and toddlers, toddlers particularly, they fall, the newly emerging teeth go into their lips, and they get a continuous ooze if they have severe haemophilia. At that time, it was sometimes people used to soak gauze swab in topical thrombin and just gently compress that against the lip, and it would mean that mucosal bleed would stop without the need for any intravenous treatment. It's always good for small children to come to a hospital without having somebody stick a needle in them. It made it less stressful and perhaps less reluctant to come again on a different occasion. We didn't use it very much, but it did have a place. Later on, it was stopped.
And then if we go to the 4th page, please, of this document. We can see this is the 1986 return for haemophilia B. 7 patients treated in 1986. And we can see there the usage is predominantly NHS factor 9 concentrate, both in hospital and at home. There is the reference to the use of commercial factor 9, and we'll come on to that later for the patient to whom that related. And then tranexamic acid is also referred to for haemophilia B patients. So by this time, 1986, is it correct to understand that all the concentrates, whether it's NHS factor 8, NHS factor 9, or the commercial concentrates, would have been heat-treated concentrates?
Yes, yes indeed.
So I'm going to come on to...
I think when you're looking at cryoprecipitate and FFP, what this doesn't give you is the number of patients who were treated with it. And in my BMJ letter, for example, I think I say that patients treated with cryoprecipitate 28 or fresh frozen plasma 3. So although the number of bags is few, because these are patients who required infrequent treatment, the number of patients treated with cryoprecipitate or FFP was actually, 31 out of 76. So almost, something like about 40% of the patients were receiving single donor treatment.
Dr. Mitchell, we're going to come on to the BMJ article next, in fact. But what I was going to suggest... No, sorry. Absolutely.
Okay.
Because we haven't looked at it in a hearing before, what I was going to suggest is we take a break now. Sarah, if that's convenient to you, it's 11:10.
Yes,
and then
it
we'll
is.
look at the BMG letter in full, as we've not previously looked at it.
Well, as I mentioned at the outset, we take a break in the morning. It'll be half an hour long, So we'll come back at 20 to 12. 20 to 12.
And sir, could you give Dr. Mitchell the usual warning?
Yes, I will. There is only your wife to talk to at home, but you mustn't talk to her, or for that matter to anyone, about the evidence you've given or you think you may yet be asked to give. You can talk about anything else you like, but not about your evidence.
Okay.
And that applies at any break. That applies.
Yes.
Thank you very much. See you at 20 to 12.